So what interventions do you do? So we set off about a bunch of laboratory tests, BU creatinine ratio, urine specific gravity, urine osmolality, urinary sodium, fractional accretion of sodium. We're trying to figure out whether this is pre-renal or whether or not the patient has ATN. And our pre-renal would indicate that you need to give more, perhaps you need to give more volume, or you got to increase the cardiac output if it's pre-renal, right? But if it's not, pre-renal and it's ATN, then the answer is doesn't necessarily mean they need more fluid. Okay, most all patients who develop acute tubular necrosis will recover, right? The creatinine may do this, it plateaus, and then it comes down, right? But the goal here is that when you're managing a patient with oliguria who has ATN, again,
what is that ATN?
Acute tubular necrosis.
Oh, okay. Sorry.
No, don't be sorry. So urinary catheter for monitoring, right? Volume challenge, plus or minus, depending on what your other information is. A loop diuretic for fluid management. That's interesting, because sometimes what I do is I know the patient's adequately volume resuscitated and they're 10 liters, 12 liters up, and their creatinine's done this, and I'll say, let's give them a big dose of Lasix to see if we can open them up. Well, what I mean by that is I'm trying to convert them from oliguria renal failure to polyuric renal failure, because patients in polyuric renal failure are much easier to manage than patients who are in oliguria renal failure, right? So we try to convert them to polyuric renal failure with a big dose of Lasix. We got to be careful to keep the poisons away, right? Adjustment of medications and doses. We got to keep, we got to avoid nephrotoxic drugs, and worst comes to worst, we put a catheter in, and they get CVVH. Okay, that's it. So remember, the keys here is that patients that we deal with, right? It's all about oxygen. And our goal is to provide enough oxygen to meet demand of the tissue. And once we do that, right, the physiological changes that you begin to see is decrease in lactate, increase in urine output, base deficit gets better. So these are all the things that we're looking at each and every day in these patients in the ICU, that when you all get these labs back and you look at these things, right, so you have a better understanding of what's going on with the patient. Or you come and say to the residents, lactate's going from 2 to 4. Patients in septic shock. What are we doing here, right? You all need to drive the bus here a little bit, right? But you all can understand this. It's just that we got to get back to, you all, instead of pushing buttons and this, that, and thing, the other. I mean, you guys are an integral part of the care of the patients in the ICU, right? You are the first line of defense for these patients, the protectors of the patients, right? I mean, when I first started, the nurses were like, I walked in, they go, who are you? I went, I said, I'm running. They go, okay. And I go, look, let me be clear here. I don't know anything. Teach me everything you know. I'm like, oh, okay. But they were very good. They were very smart. They, doing the swan stuff and taught me how to balance the swan, taught me what this means, taught me what that means, But again, that's unfortunately one of the things that's been taken away. So if we get some technology back that will invigorate everybody to look at these numbers and know what they mean, I think it's more interesting, for you. You understand more what's going on. You're more involved because you've kind of done this. And some of that's because technology has changed. The way we take care of patients has changed, And I think by generating this type of data, you all looking at it, then I think it's going to be better. All right. Right. Is this helpful?
Very, very helpful.
Okay.
I have a clear mind.
Thank you.
Good. All right.
So you feel strong to asking questions, to tell them what to do.
Yeah. No, you should.
Yeah.
You should. You should
Right.
challenge them.
I mean, not telling them what to do. I mean, for yourself, you know what is going on.
Right. But you
Yeah.
have to suggest. There's nothing. You have to make a suggestion, or you have to push them.
And
Well, what are
even
you
when
doing?
you're making this suggestion, you know what you're talking about.
You know what you're talking
Yes.
about, right? Because look, they're PGY2s. Now, this time in their training, they should be pretty good at what they're doing in terms of doing things. But in July, I got to depend on the nurses. It's dangerous, in July. These kids, they're thrown. Look, the ICU is the most dangerous place in the hospital. It's the most dangerous place. Think about it.
Yes.
Right? Technology that we use, sickest patients in the hospital, medications, drugs that we use. All this is dangerous, big time stuff. And people like to equate
Pushing
patient
people
care to the airline industry, right? Oh, we can fly a plane from here to here, you know, and it's just not the pilot, you know, and it's true here. That patient's just not about the doctor. You know, years ago, the doctor harbored all the information, right? He made all the decisions, but it's too complicated now. So, you know, a doctor by himself can't get a patient from here to here without all the other important things in the middle, which means, you know, nurses, residents, PA, whatever, you know, to get
Have you read that book, Safe Patients, Smart Hospitals?
No.
By Peter Pronovich, somebody? From John Hopkins Hospital. That's interesting.
Good book.
All things that we're doing now,
Mm.
you know, came from that time. They started because something happened in that hospital
Right.
long time ago, and then the family came in. They wanted a change. They pushed the hospital. They pushed everybody. So one of the doctors in ICU, surgical ICU, stood up, followed her, and then started working with ICU nurses and the residents. So all the protocols that we do here started at that time, because before there was nothing.
Yeah.
Before, nurses and doctors, they don't get along. Nurses are here, doctors, residents are over here.
Yeah.
They don't regard nurses.
Right.
Central lines, they can just do it anyhow,
Right.
without any they do it without using aseptic techniques.
Right.
Until then, so they started doing this.
Right.
Putting central lines, Foley catheter, all of those things, and they started incorporating nurses when they make rounds.
Right.
They ask the nurses questions, you know, they anything to say, anything to do. All those things started at that time.
Right.
And then it spread to all the other states and then international.
Nurses in the ICU can be as good as you want to be, you know, and I think that, you know, I'm really, the plan is to try, when we're moving from here to there, is that we want, you know, especially when we go to a 20-bedded unit, you know, I think, you know, nursing should have a much bigger role in the rounds in the morning than just, you know, it's like my pharmacist. I mean, she just kind of stands there, you know, and she will be happy to say nothing the whole time. Well, that's not reasonable. I know she's really, I don't say anything bad about Lisa, but she's shy. You know, she's kind of in the woodwork. If you ask her a question, she'll give you an answer. But, you know, what I have her start doing is that she'll read the medications. She needs to tell me what I should be doing differently with the medications, how I should be adjusting the doses. This is an adverse drug reaction. We should be filling out an adverse drug reaction report. You know, so everybody should have their role on rounds, and it's not just the resident who has control, because a resident sometimes doesn't necessarily have all the information either. But you guys are at the bedside all the time. I spend 10% of my time, 15% of my time at the bedside in the ICU, and then I leave.
Patient advocate.
Yeah, but that's what you have to be. But I mean, that's including their management involved in their care. All right, ladies, let's go before we get in trouble.
Thank you, Ronnie, for your
Thank you.
education.
Thank you.
Thank you.